career. He's an immunoparasitologist. He ran several clinical trials in Ethiopia through a collaborative approach with other colleagues from our side. So today he will be presenting about the ethical challenges in clinical trial. And we'll continue first to hear from his presentation, and then we'll have a discussion session later. But if every one of you feel that it's important, maybe also write in the chat box about your reflection, questions, and anything. So we will keep on questions for discussion. So Professor Asrat, welcome again. Would you share your slide? You can start sharing your slide. Bethlehem, I can see your hand. You are raising hand. Can you hear me, Bethlehem? Maybe to not have a background noise, let's make our microphone on mute mode, except the presenter. Then during the discussion time, you can unmute the microphone and then you can speak, okay? So for now, I'm requesting every one of you to mute your microphone. Alan, you are starting recording, I hope so.
Yeah, recording has been started.
Good.
Am I able to share? You must allow me, or if not.
Okay. Lana, would you allow Professor Asrat to share his screen?
Let me share their PowerPoint.
Okay, then you can do that. Still, you didn't open it. Professor Asrat, so Lalam will share the slides, and then you can just give a comment to her to continue for the next slide. Is that suitable for you?
Sure.
Great.
Okay.
Is it shared now?
Yes, you can maximize it.
Okay.
Turn it to full slide.
Perfect. Can we start now, or?
Yes, Prof. We can start now.
Okay, thank you very much. Thank you very much. Yeah, first of all, I thank the IRB at College of Health Sciences for this opportunity to share our experience discussing ethical challenges in clinical trial designs. So in this seminar, of course, we will touch upon various issues, but not all obviously. So we will be discussing selected issues. As you know, this is a wide topic, and we cannot really for this opportunity. So I'm Asrat from the College of Health Sciences myself. Next slide. So the purpose of this presentation is, if you can share the next slide, the ALM, twofold. Are you able to move the slide forward? Good, thank you very much. So, you know, we selected this topic. We thought because there's some really in terms of ethics oversight and the ethics review processes. So to fill that gap, perhaps we thought this will be a good topic for discussion today. And of course, at the end of the talk, what I intend to achieve is really to emphasize, for instance, on the importance of study design issues in matters of ethics, that is study participant protection. So that's and I hope that it will ultimately contribute to the level of rigor in terms of for the investigators writing the protocols, IRBs reviewing protocols, so they would have really more rigor, and I feel that is quite important to do, and this is basically the purpose of today's webinar. Next slide. Yeah, on this slide, you see, of course, the one in green, scientific review and ethical review are intertwined. This appears to be very obvious. It is obvious, but we are going beyond the obvious and point at issues that have relevance for ethics. This is a quote from Sioms 2009, and actually emphasizing on the scientific validity of clinical trial protocols. That's quite straightforward, but we will try to go beyond that and see what comes out. Next slide, please. In that sense, yeah. So those of you who are involved in clinical research, and particularly in clinical trials, study participants are found to really shoulder some risks, but also burden of clinical research. And the risks are important, of course, and we know that the risks mainly emanate from the the unexpected effects of new treatments, and not really from the known effects. So that's why we emphasize on really assessing risk, and therefore any participants engaged in clinical trials, they can expect them to face really increased level of risk as a result of that, but also to really shoulder the burden of clinical research. The aim of the clinical trial is not really to treat patients, but to produce some knowledge on how we treat patients or improve health. So in that respect, there are no immediate benefits. There are only foreseeable benefits, and therefore, aside from the risks, there is also really a burden of clinical research on study participants. It's important to really recognize this both risks and the burden of clinical research. Next slide, please. So indeed, we will point to the core values of research ethics, respect, beneficence, and corollary maleficence, and so on. But we will. This is quite candid issues. These are really straightforward, but of course we will time and again make references. But we will be touching up on subtle issues in the coming slides. Next slide. if one is asked to really produce a short list, kind of checklist for doing clinical research, and we end up about 7 or 8. And I believe, based on today's webinar, we would, I'm trying to convince everyone that we have to really add into this list scientific validity and also social value. So in the checklist for clinical research involving subjects. Next slide. For this purpose, we defining validity and social value. So validity is more straightforward. It's about really the research that you do has to conform to acceptable scientific standards. So in terms of study design, analysis, and etc. And the social value, remember the burden of clinical research. So it's really about advancing knowledge on how to treat patients and improving patient outcomes in clinical trials. So we have really those two elements to add into the checklist. So we will emphasize on those two in due course. Next slide. Yes, so what are the issues? What I would try is really actually try to migrate between the various issues that become concern in terms of ethics, any of these topics. And I may not emphasize on some of them, but perhaps overemphasize on other items, so that it could be one of these that we will be dwelling with in the next slides. Next slide. Now, this slide. Yeah, this is a very important slide. So it's really about the randomized controlled trials and the ethical debates about them. And remember, in a randomized controlled trial, we put a hypothesis, an hypothesis, and alternative hypothesis. And actually, what we want to do is actually to prove that the alternative hypothesis is true, it is holding true. And so, but this is not what we do randomly. There must be some background information and background data to, for us to aim at proving the alternative hypothesis is holding true. And in some ways, it means in any trial, there is a kind of intervention that is in a way favored. And another one, an arm of study, RCT, which is less favored and so on. So that in itself already introduces, bias. And in fact, there are many clinical trial experts that actually try to challenge the very notion of RCTs, conducting RCTs. And this remains to be a challenge. And as a result, there are ways of dealing around this issue. And because, we really want to protect study participants and to do that, one of the core values is really beneficence and maleficence, meaning that you want to really maximize, benefits and minimize harm. And by doing so, you are in a way, compromising, validity, the scientific validity, and that's really a problem. And some of the suggestions are, of course, working on randomization or some adaptive allocations into the arms, and a trial which appears to be favorable for the investigators. And so unequal allocation or randomization and adaptive allocation or other sophisticated clinical trials that actually try to ascertain that harm is minimized and benefit is maximized. So it's really a trade-off in a way, between scientific validity and then ascertainment of the favorable risk-benefit ratio. And that is the problem. So you have really, it's a dilemma and a compromise and a trade-off, and so this is something which we cannot help at this moment because RCTs are considered to be a gold standard for testing new interventions, and we cannot escape this dilemma. And this is really, the very first challenge concerning the ethics of conducting clinical trials in general. Next slide. Right. So all the time, trying to balance benefits and risks, and at the same time, really guaranteeing scientific validity is the main challenge. And this is, in effect, what we want to do and achieve in the oversight mechanisms. And there are issues that we cannot escape and even turn out to be a challenge for ethics. And but this is important to recognize them. And often this would begin by actually starting, defining the benefits. And sometimes we're not really sure what the benefits are. So the first step is actually defining the benefits, and that's important to do. And by the way, when you talk about benefits, it's not really about compensations or benefits that arise from the health services. It's completely different. So that's where we have to start. And but this problem is clear if you go back to the other slide. You can go back particularly in certain types of study designs. For instance, phase 1 trials. There, of course, benefits seem to be related to compensation, for instance. Okay? We will see that, but also the scientific, very valid, scientifically. But again, in terms of ethics, we have too many challenges. PCTs, it is placebo-controlled trials, and other issues. But we have other types of designs where this challenge also pops up. So in a table, next slide, you see phase 1, phase 2, and phase 3, and of course in phase 1, healthy volunteers, and but sometimes you have patients with really advanced disease, cancer, terminal stage disease, and they could be also benefiting directly, which is health benefits. But that's really unique to phase 1 studies. But benefits and risks in general are variable, and they have to be assessed case by case in the other type of trials. And this is what I would like to emphasize later on. Next slide. Oops. What happened? Do I see? Oops. All right. Thank you. Something happened in my screen. Now, considering the different types of study designs, and I think the first step is really actually knowing what protocol we are dealing with and what type of study it is, because we know, for instance, in phase 2 trials they are exploratory, whereas phase 3 trials are confirmatory, and on the oversight mechanism it should be variable, and this should be for instance, relaxing the error rates, but this is not okay of phase 3 trials, error types, error rates, particularly type 1 error. And so making this distinction is important, and as mentioned in this example, phase 2 is dealing with a homogeneous population and mechanism of action, whereas phase 3 is about really effectiveness evaluation, and especially for aiming to put that intervention in a routine care, and therefore the level of stringency is higher in phase 3 trials. I personally, I'm not really fond of phase 3 trials. I'm very much fond of phase 2, but I cannot discuss this today. It will take time to discuss that. But in any case, making the distinction between the protocols, between the study types is important. Next slide. Yeah, and then of course we have, as I said, the study designs get complicated and they get sophisticated. After the advent of RCTs long ago in the 17th century, now we have more types of study designs, and particularly CRTs or the step weight designs, for instance, and also the SHIN, controlled human infection models, which are also called the challenge studies or human challenge trials, but also the adaptive designs. They have, these are innovative trials, but they have their own problems and ethical dilemma in them. And this is really what we want to point out today in this webinar. Next slide. Now, concerning this innovative trials, complex or alternative trial designs and the ethics around them, I mean, what should be done, or what probably helps, is about transparency. And when you talk about the ethical considerations, often we are not really mentioning the limitations and the dilemma. And that is important to show, because we really want to know if there are limitations, and this should be mentioned frankly. It should be put in a transparent manner, and that helps for the oversight. In fact, it would be very helpful for the investigators and for the sponsors to actually be transparent about them, mentioning the dilemma and the ethical limitations. Should they face problems later on in due course, and because then this could be assessed in light of the dilemma already described. And previous slide again. Oops. Yeah, and not only that, it's not just about transparency, but once you recognize the limitations of the dilemma, there must be in a protocol, there must be a presentation of methods of controlling those problems. For instance, controlling systematic errors, but also safeguards concerning the study participants. If this can be done, at least the oversight mechanism will be really easier and friendly. Next slide. So concerning CRTs, this is just an example of where we have ethical dilemma, and unfortunately, CRTs, it is where we have really poor standards. The ethical considerations are vague, and the standards are not set. In many situations, this is clear, and so this is a problem for the oversight, but also for the review processes. And it's just complicated trying to balance benefit versus risks. Often the benefits first should be focusing on individual study participants, and of course then the groups. So in CRTs, this is difficult to achieve, or to devise a mechanism of achieving favorable, And in CRTs, there's one problem, which is quite common, and because this is about really the removal of equipoise, which really then affects the scientific validity of such designs. Once equipoise is removed and it's biased, it's complicated. And within CRTs, because one is dealing with groups and populations, so inherently, which comprise also individuals and groups of individuals, with diminished, capability to give consent and so on, to take decisions, and also then it's complicated, and also writing the inclusion and exclusion criteria is complicated, and the way you do the informed consent is also complicated, because if at all in such a trial there is an informed consent process, and it doesn't actually include randomization, because informed consent should be including randomization. But often what happens is that the groups are randomized first, and then informed consent is sought, at a later stage. And this is not a good practice. And therefore, we see CRTs indeed have, ethical dilemma, and this we have to appreciate. Next slide. The same phenomena concerns the stepwise designs. Basically, they are CRTs, special type of CRTs, but again, the issue here is really because of its a sequential randomization scheme, and there is temporal phenomena. So it really is a groups which is, because there is a crossover, and often to the favored arm of a study is a problem. So really, and so really sharing, the risks and the benefits becomes obscure in this kind of designs. Again, like the other CRTs, there is also removal of equipoise and also a misconception, what we call the therapeutic misconception, because often these designs are also used in public health interventions, and so that the misconception becomes a problem. And so you see CRTs, including stepwise designs, have the ethical dilemma, and this has to be recognized. Next slide. Shim. All right, now these are really very interesting designs. They are very powerful in terms of science and new knowledge that generates, controlled human infection models and challenge models, but you use them in really complex situations in medical conditions with serious morbidity and new medical conditions, emerging diseases, for which you have really lack of adequate knowledge of the disease processes, pathogenesis and sequelae, and also if there is intervention. So the limited knowledge about complications, this is a problem. And remember the story of Zika, the neurological complications in the newborns. That has been a problem, but in fact there has been shim studies in Zika, but also Ebola virus and so on. It is applied in vaccinology a lot, and so on. But so really handling issues of informed consent and what is compensation here, it is a challenge. And also, what level of compensation are we talking about? How do we get really an informed consent for healthy individuals being challenged with infection and so on and so on. So these are some ethical dilemma. But we might be facing in such designs cross reactions, disease enhancements because of other related pathogens, but also the bystander effects, transmission to second and third party at the individual level, and so this becomes an ethical dilemma in such type of designs. Next slide. Now, let us point at certain selected issues that afford to be, ethical concern in some of these complex study designs. Move on to the next slide. We'll first see into the concept of multiplicity, and whereby multiplicity is about really doing the same thing again and again, many times, as the word implies. So if you do multiple interim analysis, if you're doing instead of 2 arms, in RCT, it is nice to do just 2 arms, no interim analysis, simple and so on. But we know in many clinical trials, such as I have seen in many trials with many arms and so on, and none of them really having any conclusions at all. So multiple study arms, subgroup analysis which are not pre-planned, using multiple endpoints, composite endpoints, and so on and so on. This really bring about bias, and a systematic bias, and often leading to false positive, sometimes also false negative errors. And this is really a major issue that IRBs and whoever is involved in oversight mechanisms, but including the investigators and sponsors to be aware of, trying to avoid really multiplicity. Or if not, if it is not scalable, then to put in a mechanism to control, the occurrence of systematic errors like type 1, type 2. Next slide. It would be nice to actually point at different types of bias, but here I have deliberately selected this type of bias. But this concerns really for the moment clinician decides to be an investigator, and we know they would run duty and their obligation to treat their patients. And at the same time, they happen to be investigators. And so they really have this competing interest of treating patients or on the other hand, but also, trying to be an investigator. And because this will definitely affect the perception of the investigator concerning equipoise, and also will affect the informed consent process. It will affect the allocation, and so this needs to be avoided. And a clinical trial protocol during review, so we cannot ignore really who is, taking consent, for instance. What are the processes? Who is doing it? It does appear to be just a simple mechanistic phenomena, but it is not. It's about really avoiding bias. And in the event that in the audience, some of you would be serving as clinician investigator, you probably would decide. There are other types of bias, just 2 examples here. Contamination bias, we will not discuss them in detail, and also maturation bias. Often this type of biases arise as knowledge is advanced, and as clinical trials progress, and so there's really a new type of biases that can affect the validity of the science that we do in this type of research. Next slide. Another issue is the endpoint selection and also switching, and but this is really important, and this is about what markers one would be using in measuring outcomes, whether one is using clinical markers or biomarkers, surrogate markers. And as we know, the markers should be clinically relevant. They must be measurable. All, they must be really sensitive to, must be pre-specified, and they cannot be switched. And suddenly investigators switch. This is a bad, ethical practice. So this should be avoided. So at first, at the outset, one should really be sure of what biomarker is really appropriate because of these temporal outcomes and adverse events. So really selecting the best marker is important, but also pre-specifying them at the outset. Just 2 examples, 2 groups of examples here. The intraocular pressure, you agree that's probably will be a good marker for glaucoma, and blood pressures. Measuring blood pressures would be good markers for cardiovascular disease. If you're trying to really use other biomarkers for cardiovascular disease, a number of them, and you are unsure they are really good enough. And at the bottom, you see PSA, bone density, and of course glycated hemoglobin, and each of them there seems to be consensus they probably are not good markers. Prostate cancer and maybe osteoporosis and blood sugar levels in diabetes. Therefore, it's really about selecting the best sensitive marker, but also pre-specifying them at the outset. Next slide. Yes, this is just another example of acute heart failure therapeutic trials, whereby somebody is really targeting congestion, and one is wanting to have and so it's like, because often congestion is difficult to predict, you know, the pathophysiology of it, and therefore, you know, taking note of, you know, the medical conditions under consideration and choosing the right biomarker is a challenge. You can see that in the next slide. There we have seen some markers, biomarkers, examples, congestion. Perhaps there are some peptides that I have seen could be used. If you're aiming to really rely on myocardial injury, which may not be a good idea, you know, if you are actually targeting acute heart failure, but troponins maybe, but also renal function alterations. You know, cystatin C and others. But at others, again, it depends. If one is really working on say, in the ICU, you know, critical care, and one is doing research in improving, you know, outcomes in the critical care, perhaps you could use DAS, because DAS is a frequent phenomenon in a critical care condition. And so really taking a decision about the markers is important, and it is an ethical imperative. And as I said, you could plan to use composite endpoints. Again, the problem is multiplicity. But all this depends also on what you want to achieve in a clinical trial, the aims of the study, whether you want to alleviate acute systems or achieve a biochemical decongestion, reduce mortality, injury to the heart, and whatnot. So, you know, it also depends on what is the primary aim of the study. So really, the selection of endpoints and defining them at the outset is important, challenge in many situations, and therefore, really, issues of endpoints should be discussed at depth during review of protocols, and because they can be really serious. Next slide. Another issue is about early. I mean, trials could be stopped early for good reasons and bad reasons, which I will show. But if you decide to stop clinical trials for reasons of efficacy, and this is a slide about stopping trials for reasons of efficacy, so it's about early stoppage. As you know, it's good to stop early. It's an incentive for everyone, you know, all stakeholders of clinical trial. As investigators, it's less work. Okay, you're done. You can produce publications sooner and so on. For study participants, again, it's relieving the burden and the risks for, you know, the also for the sponsors, it's less money, less responsibility, and so on. So it's really what is the price of that. And the first thing is that there is a limited risk information that can be generated by stopping early, because we are talking about new interventions, and the risks so when trials are stopped, so there is, and of course the estimate effect and bias, and of course then really stopping trials for reasons of efficacy is not an easy matter. It has a lot of ethical implications, but you could stop trials for a number of other reasons. Next slide. So, again, there are quite a number of trial experts who actually are against stopping trials for reasons of efficacy. So it's just to manage expectations. And Okay. In any case, there should be really, if there is a decision at the outset, at the design level, to stop trials for reasons of efficacy, there must be good justifications and preconditions for stopping it in detail, and this should be assessed. Next slide. So, if you emphasize the good reasons for stopping truncating trials, yeah, obvious ones in green here: the unfavorable benefit-risk ratio, very serious harm. You can stop them. This is acceptable. But also futility. If the trial, when it progresses, does not produce any results, it is just futile to go ahead. And because of futility, you can still stop it, and this is acceptable. But again, there are a number of other reasons. There are feasibility issue, ethical issue, any other concern, and if the same trial is going on elsewhere and there is data that has emerged, then there is a good justification to stop trials. But the bad reasons, we don't have to spend time on them. It's really about misconduct, research misconduct, and management, so the suppression of negative results, and so on, and administrative changes. Okay, but there are good reasons to stop trials. So next slide. Now, therefore, the main reason for truncating clinical trials should be, the focus should be about participant protection. It's not really about efficacy, and this should be based on in light of the assessments that one takes, in terms of the benefit-risk ratio. That's the key message here about truncating clinical trial participants. Next slide. And of course, when it happens that the trial has to be stopped for efficacy, and if this is proposed by the sponsors and investigators, there must be really a detailed examination of stopping criteria, including the statistics, and there must be really emphasis on very conservative stopping rules, and this must be scrutinized. And this is really the task of IRBs. So they need to have expertise about study designs and statistical assistance, and this should be done at the level of IRB and so on. Next slide. Now, of course, statistical analysis. This is another major issue that needs to be pointed out. For the study designs, and it's not uncommon that in fact they also suddenly decide to use certain statistics which is not pre-specified, and we are saying the statistical analysis plan should be pre-specified or pre-developed and included in a clinical trial protocol, and therefore any deviations would be a problem, or any new statistics that you incorporate during data analysis will be unethical, and this should be prevented. And because what happens is then, once data is accrued, people play around the data and see how it looks like, and dredge through the data or torture it, and then at the end choose a statistics that will be in favor of really finding a significant p-value, and then this is really what we call spinning of results, and this should be prevented from happening. And it is not a rare event. We see it happening, we see it in the literature, and it's a big problem, and this should be avoided. But it's by the same token also, you change the endpoints from primary to secondary, because the primary endpoints don't produce you statistically significant difference, and you revert to secondary endpoints, and you do analyze, and you get some significant differences, and on the basis of which you really make the conclusions. This is this is bad practice again. So the statistical plan should be pre-developed upfront. Next slide. We're coming to a close, and you see that, you know, in many publications, you see power analysis is done post hoc. This is inappropriate. Okay, and because of the lack of the, you know, predefined statistical planning, you know, also the sample size calculations, people start to calculate power later on, you know, once the data has been approved. This is a post hoc power analysis. It's inappropriate. Okay, so this should be avoided, and that's why we emphasize on the statistical analysis plan. At the bottom right, you see a small table, but this is again multiplicity. You see if the data is analyzed 1 time, 2 times, or the number of tests you employ is just 1, 2, or 10, you see the false positive rate going up from 5 to 10 and up to 40%. It's a real problem, and this should be recognized. Next slide. So because clinical trials are based on study designs, and one has to pick the right statistics. And if anyone is involved in a superiority trial design, typically you would go for ITT, intention to treat analysis. And otherwise, if it is a non-inferiority trial design, typically use a per protocol. But this should be defined per protocol at the outset. And so the statistics is really study design based, and this should be clear to investigators and people who are, you know, looking into oversight. Next slide. We are almost finishing. Sorry for the longer time taking. There's one aspect that is also an ethical issue.
It's okay, Prof. We are within time. It's okay.
Okay. Thank you very much. Thank you very much. So not publishing negative results. You all know this. Okay, but this is but the other issues are really, again, very dangerous. It's often not noticed, is about really spinning. You know, even the title of the articles that you publish are completely different from what is written in the protocol. They don't have to be identical, but at least they should not be misleading. You know, even when you read the title, you know the conclusions. So that's really a very misleading title of articles, and we call this a spinning, and this has to be avoided. And the other common problem related to publication is the comparisons. You design a multi-arm clinical trial, and when you report C versus C, C versus D, whatever it is, and you're just reporting, you know, the single comparisons. But whereas the trial itself is really a multi-arm clinical trial, it should have its own method of analysis. And when people report it, they just do single comparisons. This is also bad practice. And in fact, the extreme case is that people are reporting, you know, the single comparisons in different publications. You make many publications. So A versus B is one publication. You know, C versus D is another publication concerning, you know, publications. And we have to prevent this from happening. And investigators have to be aware of this problem that we have in terms of publications. I think I'm probably done, and I would be happy to take questions. As do you have any more slides? Let's see if we have any more slides. But yeah, thank you very much. So we've just done this, and I'm back to you.
Thank you. Yeah. Thank you, Professor Asrat, for your nice presentation and sharing your experience, the issue of ethical challenges in conducting clinical trial related to the study design. So now the floor is open for discussion, questions, and a reflection about the area. You can unmute yourself and speak. Any question?
May I, Dr. Solomon?
Okay.
Am I allowed?
Yes, sure, doctor. Please go on.
Thank you, Prof, for such an enlightening presentation. And we are happy as IRB members, since we see many of these papers on clinical trials nowadays. So it's really, this was an opportunity for me also, as I remember, to hear a lot about IRB trial, the clinical trial challenges, ethical challenges. Now, maybe as a clinician, I have just one question for you. The issue you raised, like the dual role of a clinician and as an investigator. At times, person could be at the only person in that area who could really offer that treatment for patients, but still that person could be a PI or an investigator for clinical trial. In those situations, maybe what do you like to advise us? Let's say the role of blinding and so on. That was there anything, I will be happy to hear from you in that area. Thank you.
Okay. Okay, thank you, Doctor. So, Prof, can you proceed? Meanwhile, other questions are coming. Yeah.
Okay, sure. We can address this. It was, I think, Dr. Marem who asked this question, the dual role. It is indeed a concern, but again, clinical trials, physicians should be in charge of clinical trials, obviously. And because they are the most knowledgeable and they are in the best position to manage any problems that arise. And it is a responsibility. And as a matter of fact, we try to encourage clinicians to be in charge of leading a clinical trial as PIs, if possible, if not as co-PIs. But this, so the message that I was trying to convey is really mainly concerning some technicalities, like if you want to get, of course there is blinding, but still, as I mentioned, we know there is really a favored treatment. So as a physician, when you know this arm is better than the other arm and you are unhappy about your patient going to the less favored arm, it happens. It's human nature, isn't it? And so what do? You get worried, and some people, some physicians, they actually, because they know their patients, their conditions, even though they do meet inclusion and exclusion criteria, they have specific needs, but they try not to include them in a trial also, right? But this is for good reason. And so, it's tricky. And the fact that really now you lose, the confidence in the issue of equipoise, the uncertainty about what you could do is really try to avoid engaging in, this in-depth communication with patients, maybe, but might be difficult to do so. But sharing responsibilities is one. So perhaps as a PI, you may not really want to be involved in allocation. Somebody else can be delegated to do the allocation. Another person could be involved in taking consent, for instance, the informed consent, and another set of patients, because this is clinical trials, is a teamwork, and the other task is really the daily management of patients, treatments, addressing the needs of patients, could be done by another set of clinicians, and so on, But again, it would be nice if clinicians become really on the leading parts, organizing the overall trial, the progress, and so on, and monitoring the progress and giving technical advice, technical advice that is in place, and so on. But conversations with patients, concerning the treatments, it is a challenge. So yes, I try to share responsibilities is the answer, as far as I am concerned, and especially trying to the informal consent taking at least.
Okay. Okay. Thank you, Prof. Yeah, Dr. Shifarao pointed out the major challenge in when clinicians are engaged in clinical trial at the same time as a clinician. So I hope Dr. Shifarao has got this the answer. And the delegation
Thank
of
you very much.
tasks. Yeah, thank you very much, Professor Asrat. Then I've got also a question from one of the participants, Haile Mikhail. His question is, how do we harmonize the principle of don't harm and the CHIA, the human infection model, I think he wants to say like that, which is controlled harm. Professor Asrat, would you reflect on this question from one of the participants, Haile Mikhail? Or Haile Mikhail, are you around?
Yeah.
You can unmute your mic and speak out. Haile Mikhail.
Hello?
Yeah. Yes, we can hear you.
Can you hear me, Dr. Solomon?
Yes, we can hear you.
Okay. Thank you, Professor Asrat, for the enlightening presentation. Just, I think when we start our basic research ethics training, usually we start from the Hippocrates oaths, that is, do not harm. But in the controlled human infection model, we are introducing harm, even though we thought that we control the harm. So how do we, make a compromise between advancing science and protecting the principles, of ethics and the like? That's what I would like to just share. Yeah, thank you.
Okay, Prof.
Okay, yeah, indeed. Of course, this is an extreme type of example we have picked up. And so people try to, this is not really a widely used study design. You use them under special circumstances, and you make sure there is a controlled environment to do it. You cannot do it in the open. And the level of stringency and oversight is very strict. In fact, there is a real-time follow-up of such designs, and because they are complicated, and as you said, there's really significant harm, and it's complicated. Talking about compensation, what do you mean by compensation? What good does it do? To begin with, you are actually introducing harm, and in this particular type of designs. But remember, phase 1 trials also, you're using healthy individuals, right? Usually, and those guys, they do foresee some benefits, short-term benefits, and not really long-term benefits. And there also is a challenge. It's healthy individuals. So what is a rationale of having them here? So only that it's a social value maybe, and based on the altruistic motives, such individuals are ready to really shoulder, such a burden of, risky research, and so it is a problem, as you said. It is indeed a problem, and there's no way. I mean, it's that you can actually balance, benefits and harm in this circumstance, and so actually they, if they have to studies, and there's no solution to it, and but this is peculiar. It's also about phase 1 trials, but also human challenge infections. So they rationale is that it is controlled. We have a stringent systems, stringent systems, for handling risks and so on. They say, and but in any case, this is done by the most experienced, by multi-stakeholder, engagements like WHO, for instance, for Ebola. They had a shim study for Ebola, which was complicated, a lot of challenges, as we know it, concerning Ebola. But it is a challenge. I don't have anything else to say, but we know it is a challenge. But it does require the highest level of stringency, ethical stringency, to do such type of studies, such that you minimize risks. There is actually no benefits. There is no benefit, but it's about minimizing risks to protect, the life of such individuals. I hope, Dr. Haile Michael, this is sufficient, but it is indeed a problem. There is no benefit here.
Thank you, Professor Asrat. Yes, it's true, especially the controlled infection model is stringent, and also it demands a special facility setting with experience and knowledge about the pathogen itself.
Yeah.
So yeah, you're right. So I hope Dr. Haile Michael got the point. And we have got also one more point from Habtamu. It's the question is when is the right time of waiving informed consent, with some practical example in the Ethiopian situation. He wrote it like this. But again, if Habtamu, you are with us, you can have a minute to correctly rephrase what you mean by the waiving of informed consent for studies, especially in relation to our today's discussion. You can have the right opportunity with Professor Asrat to talk to. So Habtamu, can you hear me? Hello, Habtamu. Your microphone is on mute mode. Okay. Okay. If they are not listening us.
I think.
Okay. Yeah, he's in the library, so yeah, he may not speak. He's attending in the library. So, Prof, maybe you can.
Yeah, fine. That's good. That's good. Thanks for the question, Habtamu. But remember, today we're discussing clinical trials, so, first and foremost, and really a waiver of consent concerning clinical trials. There is limited opportunity, and I mentioned the CRTs because of the vague situation there. And, some people, they write the CRT, cluster randomized trial, and they say concerning the individuals, you ask a waiver, and of course for the community, because it's difficult to take consent from the community. So you trying to, through the health system, you do it with the health system, maybe community leaders, you take kind of waiver of consent in a way, and there, as I said, it's the club incident, and I don't believe this. You could do perhaps waiver for at the community level, but at the individual level, perhaps I think because the individuals are varied, different needs, and perhaps there at the individual level you need to have an informed consent for that purpose. But again, if you look at critical care patients, even there, patients are in a diminished autonomy to decide. And looks like might be deciding on their behalf, or the best of, or a guardian, or ask it to consent in their favor. And this is not still a waiver, but it's still a consent, and the consent should take place continuously, consenting, reconsenting, and so on, as patients recover, improve. This has to be, but we're talking about clinical trials. Of course, there are other type of study designs, epidemiology and whatnot, whereby you are actually could be a way out for doing, waiver of consent. But we are really discussing clinical trials, and we have to be aware of that. So there is limited option for waivers like that. So I think, yeah, it's problematic, and it's not widely advisable to really go for a waiver concerning evaluations of interventions, which is clinical trials in this case. Okay.
Okay, thank you, Professor Asrat. Yeah. Okay, so any other point of discussion from audience? Okay. I think, yeah, that's the chat box. I didn't find any more question. And yeah, I think with this, we shall.
Don't forget, Dr. Solomon, there are many people asking to share the
Oh yeah, yes,
presentation to-
Doctor.
yeah, thank you.
Barra,
Please
yes,
politely.
yes. Thank you for reminding me. Yes, we will share you the record through YouTube. We'll share you the link for the YouTube, and it will be an open access presentation. I hope the presenters give us a consent. Probably we have as we are working in the IRB, we have to also get consent from the presenters. So on all the presenters, if they give us a consent, we will share their presentation on the YouTube. So we will do that. Okay.
Hope it is not written consent.
Ah, yeah, that's another issue. Okay.
I do give consent to be shared. This is really important that it is shared as well if they find it important.
Good, great, thank you, Professor Asrat. So I think with this, we will wind up our today's webinar. It was a great time, and by the name of our IRB, I would like to acknowledge Professor Asrat for sharing his experience on ethical challenges related to study design, in particular in clinical trial. It was a great session, and I hope all of you get benefit out of it for your future research endeavor. You will exploit this knowledge. I would like to thank you again, Professor Asrat, and all of you, all the attendants, for joining us. And see you next month with another topic. Thank you very much.
Sorry, Dr. Solomon, can I ask a question?
Oh, okay. Please go on. Okay.
Let's say a child who's 12 years old at some clinical trial site, and his family want him to be participated or be a subject of study, but the child refused to be participated. In this case, what shall we do?
Okay.
Dr. Solomon, you can also.
Yeah, please, Prof. Today you are the master of the ceremony.
So yeah, of course, I think the question is, it's also the assent. If the investigator fails to obtain assent, but the family insists, well, of course, this is a child, and the family is what gives the informed consent. They sign, on behalf of the child, but the child refuses to give assent, and we don't know how old the child is anyway, but in as much as,
let's say he's 12 years old,
is capable of taking decision, is capable of understanding what is going on. And, yes, they are less than 12, even 7 years old these days. Children have the capability to grasp some notions and ideas, and we should really, try to respect their stand. And if they refuse to be part of it, well, I think we have to respect it.
Thank you, Prof. Yeah, it's true that we don't need to only refer the year. For the sake of operation, we have assent, as Professor Asrat said, from age of 12 up to 17, just before 18-year-old. we ask assent from a child and consent from a parent. But if any participant, irrespective of their age, if they refuse, if we feel that they are not what they don't want to participate, we shall give the respect as well. It's not only a matter of assent as well. So we should feel their emotion as well.
Yeah.
So as Professor Asrat said, the respect component of ethical principle should not be overlooked by only the cut of the age. Even a 10-year-old child who's just strongly refused to be participant of the study unless otherwise there is a public health issue that enforces the individual to be a participant, again we have to respect that individual. So there is dilemma in any way when we should allow these minors to be a participant in the study. Thank you, Mahdi. Okay, any other point of discussion after the close-up? Okay, anyway, I think with this we shall wind up today's webinar. Thank you, Professor Asrat, again, and thank you all. If there is any question or any topic of interest that can be used for future webinar, again, you can forward us. You can forward your topic to the RB and person like Professor Asrat, and his colleagues can also be engaged in this type of webinar, and we will make it happen. Thank you very much. Have a nice day for all of you.
Thank you very much, Dr. Solomon, and the rest of you in the audience. Thank you.
Thank you. Good day.
Thank you so much.
Thank you.